Hi, my name is Christine Kya, and my mentor is Dr. Ogrider. And my topic is on the success of the RhoGAM vaccine on erythroblastosis fatalis. So, what is erythroblastosis fatalis? We'll start from the beginning at fetal development during pregnancy. So, the fetus gets all of its nutrients that it needs to grow during the 40 weeks of gestation from the mother through placental exchange, like nutrients and oxygen. But this also means that blood exchange also occurs across the placenta. And before we get more into blood, different like the passage of blood between mother and fetus, we'll talk about blood typing. So on the surface of red blood cells are different glycoproteins. So antigens such as A, B, AB, which if you have both A and B on the red blood cell, or O, and RH. RH is the rhesus factor that basically determines if your blood type is going to be either A positive, which would mean you have the RH factor on your red blood cell, or you could be A negative, which means you don't. But this can also lead to a mismatch of blood types between like receivers and blood donors. So if you were a receiver and you were A negative and your donor was A positive, then your body could become sensitized to the exposure of A positive blood because you've never had it, and your body could build antibodies against the donor's blood, which basically means you won't receive it, and your blood will attack the donor's blood, and it'll cause hemolysis. So this can also happen between maternal and fetus, and like between mothers and their fetuses. So the fetuses, like erythrocytes, can diffuse through the placenta and enter the mother's body. And this just leads to sensitization in the mother, which basically after sensitization occurs, antibodies can be built by the mother, which will then attack the fetus. It takes a little bit of time to occur, so it won't happen if the mother's first child is Rh positive. It'll be more lethal and fatal for the second or third child that is Rh positive. And basically, after sensitization, the red blood cells and antibodies can cross the placenta, and it'll basically attack the mother's antibodies, will attack the fetus's blood and either destroy the fetus, or if it doesn't destroy the fetus, then it'll lead to erythroblastosis fatalis, which is just another name for the hemolytic disease of fetus and newborns. And this picture just shows a diagram of how the red blood cells will go through the placenta. The Rh plus factors will cross through the placenta and move into the mother. So prior to the RhoGAM vaccines, prior to the invention of the RhoGAM vaccine, they used to do intrauterine exchange transfusion, which is basically when they take all the baby's blood out and replace it with donor O negative blood. And there's a lot of stipulations against this just because the red blood cells must be fairly fresh. It has to be less than 7 days since it's been drawn from the donor. And usually this does consist of multiple transfusions, and it takes more than one transfusion for it to work. And then it's also a financial burden because you'll have to keep doing it. But there was a study done in 1963 by Liley to see the success rates of preventing erythroblastosis fatalis in newborns. And he performed in fetuses, and he performed on 4 fetuses, and he did have a success rate of only 25%. So what he did was he transfused 155 milliliters per kilogram of O negative donor blood, and he transfused it into 4 different fetuses with mothers who were Rh negative. And 2 of them died within the first 24 hours of transfusion. The third fetus received the first transfusion and was fine, and then received the second transfusion at around 31 and 33 weeks of gestation, and he died within a few hours of the second dose. And the fourth fetus did survive both doses and was delivered at 34 weeks gestation, but he was, that is considered premature, and they were delivered via C-section. And the placenta had coloration of severe hemolytic disease. So the baby didn't have it, but the placenta showed signs of it. And that's just a picture of how the intrauterine exchange transfusion was done. They go through the umbilical cord and through the umbilical cord and into the umbilical vein, and then that's where they do the transfusion. And then ultrasound is there the entire time to detect the vein. So another study was done by Swinhoe in 1990 to see if intrauterine transfusion can help patients who are already suffering from erythroblastosis fatalis. And so he performed on 18 patients who had severe hemolytic diseases because of their inability to get the RhoGAM vaccine. And out of 18 patients, 12 of them survived. So he did have a higher success rate of 67% approximately. And but all of the patients, again, who survived were delivered via C-section. So they were not delivered naturally. And the little table at the bottom just shows all the patients that were in it, and 12 patients who survived, and 5 of them died due to complications during transfusion, and then 1 was stillborn, which just means that they died after 20 weeks of gestation. What is the RhoGAM vaccine? So it was founded in 1960 by physicians at Columbia University. It's composed of anti-D immunoglobulin, which is the rhesus factor. It just shows that if it's given to, if the antibodies are exposed to the mother before her body has a chance to produce it, it's not as lethal. And it's given to every Rh negative mother at 28 weeks of gestation. And then it also, like I said, prevents the production of antibodies in maternal hemoglobin for the rhesus factor if they're already exposed to it if they're already exposed to the antibody. And they are the picture at the bottom are the 2 physicians that invented it, Dr. Gorman and Dr. Frieda from Columbia University. And so there's been many research done on the effects of the RhoGAM on hemolytic disease of the newborn. In 1969, a group of researchers compiled research from over 2,000 cases, where RhoGAM was administered to Rh negative mothers. And the result came back with 100% of the time the prevention of sensitization. So sensitization, again, is the ability for the mother to not produce antibodies against the newborn, against the fetus. But then they also looked at 1,000 cases where it was not used, where the RhoGAM vaccine was not used, and sensitization occurred in approximately 7 to 8%. So that's around 70 to 80 mothers who started producing antibodies against their fetus. And another research was conducted in 1967 by a group of researchers, again, to show the effective rates of preventing erythroblastosis fatalis. And it just showed that 322 mothers were given only 1 milliliter of anti-Rh gamma globulin, which is the RhoGAM vaccine, containing 300 micrograms of the antibody. And it was 100% effective. 322 mothers, none of them produced any antibodies, none of them became sensitized to their fetus. And they were also, 305 mothers were in the control group, and they weren't given any RhoGAM vaccines, and approximately 32 of them produced Rh antibodies out of 305. So approximately 10% became sensitized and produced antibodies against their fetuses after 6 months of delivery. After 6 months after delivery. And then earlier this year, there was another group of researchers who compiled 24 different studies done on the effectiveness of RhoGAM and the various number of injections given to the mother during pregnancy. And it consisted of the 64,860 patients. And they were given varying dosage, like I said, but the same injection, so 300 micrograms of RhoGAM. And the first group received 2 doses at 28 weeks gestation and then again at 34 weeks gestation. And the effective rate is 96.8%, and that's the Sucra score. Sucra score is just a metric way to evaluate the most effective treatment in comparison to other treatments. And the group 1 had the highest effective rate at 96.8%, which means only 96.8% of mothers, 96.8% of mothers didn't produce antibodies against their fetus. Group 2 received only 1 injection at 28 weeks gestation, with their Sucra score being 89.2%. Still good, but not as good as the first group. And then the control group, group 3, did not receive any injections, and their Sucra score was 0.0%. And so that means that all the mothers did produce antibodies against their fetus. And the graph on the side just shows the different percentages. So in conclusion, why is the RhoGAM vaccine the most effective treatment for erythroblastosis fatalis? It continually proves that it is 100% effective. All research has shown that in every mother that's been given RhoGAM, that they have not become sensitized to their fetus. And it is widely used in Western medicine because 15% of Americans are Rh negative. So that's a lot of mothers who could be potentially exposed to Rh positive babies, which would just lead to erythroblastosis fatalis if they didn't have the RhoGAM vaccine. And before the vaccine was invented, approximately 10,000 newborns died every year from hemolytic diseases of the newborn. And after it got invented, it got eradicated, and now it's only down to 1% of 1% of newborns get erythroblastosis fatalis. So the next step would be to make it more readily available for developing countries who don't have as well of an access to it that we do in Western countries, because now there are screening procedures and protocols in prenatal care for mothers that require them to be screened for Rh if they are Rh positive or negative. And then if they are negative, then they do get the vaccine. And so, but there are a lot of foundations that are looking into helping developing countries, such as CURE, which is started by neonatologists from Stanford University. And it's basically, their cause is to eradicate Rh disease worldwide by making it more affordable and accessible. And the RhoGAM vaccine can also assist in future vaccines, like inventing future vaccines for ABO incompatibility due to other antibodies, because there's still anti-C antibodies and anti-E antibodies that can still cause hemolytic diseases. Anti-D was just the most prominent antibody that causes erythroblastosis fatalis. So there's still a lot they can do to find other vaccines for, to aid in finding vaccines for other antibodies that causes diseases in newborns and fetuses. But this is my list of sources, and thank you, Dr. O, for helping me. And that's it. Thank you.